Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. In this video, we are going to talk about gallbladder disorders. So, which of the following diagnostic test disorders would be most specific for acute cholecystitis? A 50-year-old woman comes to the emergency department with severe upper abdominal pain. The pain started suddenly and is sharp and colicky. He has also vomited several times throughout the day, including once while in the emergency department. The patient describes several prior episodes of similar abdominal pain that resolved spontaneously without treatment. Her other medical problems include complicated appendicitis when she was 22 years old. Her temperature is 100 degree Fahrenheit and pulse is 112 per minute. Abdominal examination shows cessation of inspiration with deep palpation of the right upper quadrant. Lab assessment shows a bilirubin level of 0.8 mg per deciliter and a serum alkaline phosphatase of 100 units per liter. Initial imaging studies are equivocal. Which of the following diagnostic tests will be most specific for acute cholecystitis? Distended duodenum on upper gastrointestinal series, echogenic structures inside the gallbladder on abdominal ultrasound, failed gallbladder visualization on radionuclide biliary scan, increased serum aspartate and alanine aminotransferase levels, opacities in the right subcostal area on abdominal X-ray. So, acute cholecystitis is caused by gallstone obstruction of the cystic duct in more than 90% of the cases. Ingestion of fatty fluids then stimulates the contraction of the gallbladder against the impacted stone, resulting in severe colic pain. Mechanical disruption of the gallbladder mucosa and release of the inflammatory mediators cause the obstructed gallbladder to become inflamed and edematous. As blood supply to the distended organ becomes compromised, secondary bacterial infection frequently develops. Potential complications include gangrene and perforation, with subsequent formation of a uh, pericholecystic abscess or generalized peritonitis. Ultrasonography is the preferred initial imaging test for the diagnosis of acute cholecystitis. However, nuclear medicine hepatobiliary scanning can be an alternate means when ultrasonography is inconclusive. Now, during a hepatobiliary scan, a radio tracer is administered intravenously and is preferentially taken up by the hepatocytes and excreted into the bile. Images of the tracer as it moves through the hepatobiliary system and intestine are then obtained for up to several hours after injection. Here you can see the images. So, in patient with a patent cystic duct, the gallbladder will be seen as the radio tracer accumulates and concentrates within, like in image C. In acute chronic cholecystitis, the radio tracer will be taken up by the liver with progressive excretion into the common bile duct and proximal small bowel, but the gallbladder will not be visualized due to the obstruction of the image A and image B. Here you can see the liver has taken up the tracer, but the gallbladder is not visualized. Now let's talk about the anatomy of the duodenum and the biliary tract. So this is the gallbladder, and now this is the fundus of the gallbladder, and this is the gallbladder body. And this is the potential site for the gallbladder duodenal fistula or the gallstone ileus. This is the neck of the gallbladder. This is the neck of the gallbladder. This is the cystic duct. This is the right and left hepatic duct. This is the common hepatic duct. And this is the common bile duct. And this common bile duct and the main pancreatic duct opens up in the second part of the duodenum via the hepatoduodenal ampulla of Vater or the mesoduodenal papilla of the Vater. Now let's talk about the pathogenesis of the pigment stones. Now, the black stones are formed when there is chronic hemolysis. For example, cases like sickle cell, spherocytosis, or there is increased intrahepatic cycling of the bilirubin. Example, ileal disease. Or the brown stones are formed by the biliary tract infection. Example, Escherichia coli, liver fluid, and they release the microbial beta glucuronidases. Now, why these color are important? Because sometimes the USMLE just shows you the gross picture of the stones and asks you what may be the cause of the stone formation. If the stones are black, it may be due to the chronic hemolysis. If the stones are brown, it may be due to the biliary tract infection. This increases the unconjugated bilirubin, and subsequently the calcium bilirubin precipitation leads to the formation of gallbladder stones or the pigment stones. Here you can see the mixed stones in picture 1 and gallbladder with acute superimposed on the chronic cholecystitis, showing 3 small mixed stones and a large single combined stone. Now let's review the cholelithiasis part of your first aid. So wherever there is increased cholesterol and under bilirubin, there is decreased bile salts and gallbladder stasis. It all causes the sloghs or the stones. So there are generally 2 types of stone: cholesterol stones and the pigment stone. The cholesterol stones are the radiolucent stone, and it is associated with obesity, Crohn's disease, advanced age, estrogen therapy, multiplicity, rapid weight loss, medications, example fibrates, and increased incidence in the Native American populations. Pigment stones, black, radiopaque, calcium bilirubinate, as we have seen earlier. Hemolysis produces brown, which is radiolucent, associated with Crohn's disease, chronic hemolysis, alcoholic cirrhosis, advanced age, biliary infections, and total parenteral nutrition. The Crohn's disease, it predisposes not only to the gallbladder stones, but also the kidney stones. The most common complication is cholecystitis, and can also cause acute pancreatitis, acute cholangitis. The diagnosis is with ultrasound, and we need to treat it with elective cholecystectomy if symptomatic. There are major risk factors involved in the development of the Cholelithiasis. And these are remembered like the 5F: female, fat, fertile, above 40, and inferior individuals, or you can say the American population. So whenever there is in patients like a female, if the age is more than 40, in obese individuals and those who have a genetic predisposition, there is a decrease cholesterol 7-alpha hydroxylase, and that increases the cholesterol and decreases the bile salts and causes the gallbladder stasis. Now, this causes the supersaturation of bile with cholesterol and forms the cholesterol stones. In case of chronic hemolysis, there is increased unconjugated bilirubin and supersaturation of bile with calcium bilirubinate, and this is how pigment stones are formed. Now let's talk about some related pathologies of the gallbladder, like the biliary colic, Choledocholithiasis, and cholecystitis. So associated with nausea, vomiting, and dull right upper quadrant pain is the biliary colic. The neurohormonal activation, example, the cholecystokinin after a fatty meal triggers the contraction of the gallbladder, forcing stone into the cystic duct. And labs are normal and ultrasound show cholelithiasis. So whenever there is stone in the gallbladder, and whenever a patient takes a fatty food, the patient may be asymptomatic before that, but whenever the patient takes a fatty food, then due to the cholecystokinin action, the gallbladder contracts. And whenever the gallbladder contracts, it pushes the stones towards the cystic duct, and that leads to the dull right upper quadrant pain, which may be associated with vomiting also. So the labs are normal in these cases, but when you do an ultrasound, then you can see the gallbladder stones, maybe in the gallbladder or in the cystic duct. Choledocholithiasis, there is the presence of gallstones in the common bile duct, often leading to the elevated ALP, GGT, direct bilirubin, or AST/ALT. So whenever now the stones from the cystic duct have passed towards the common bile duct, and if it is in the common bile duct, then that will lead to the choledocholithiasis. The difference between biliary colic and choledocholithiasis is that the labs are normal in biliary colic, but it is abnormal in case of choledocholithiasis. Cholecystitis भनेको acute or chronic inflammation of the bladder. Calculus cholecystitis, most common type due to the gallstone impacted into the cystic duct, resulting in inflammation and gallbladder wall thickening, and can produce the secondary infection. Acalculous cholecystitis is due to the gallbladder stasis, hypoperfusion, or infection like the cytomegalovirus infection, and it is seen in critically ill patient. So the patient, in case of the patient who are critically ill, the patient who are immunocompromised and are at increased risk of CMV, like AIDS patient. These HIV/AIDS patients are at increased risk of acalculous cholecystitis, and this is due to the gallbladder stasis. It is in the name itself, acalculous. The stone is not involved, only the gallbladder is involved. Murphy sign, whenever there is inspiratory arrest on the right upper quadrant palpation due to the pain, it is called as the Murphy sign. The pain may radiate to the right soja due to the irritational phrenic nerve, and there is increased ALP if bile duct becomes involved. Example, acute cholangitis. The diagnosis is with HIDA scan, the scan that that you have seen in the first part of the video, the gallbladder tracer and all, where you will be where you will not be able to visualize the gallbladder on the HIDA scan, suggests the obstruction. Gallstone is ileus. So there is the fistula between the gallbladder and the GI tract. The stone enters the GI lumen and obstructs at the ileocecal valve. That is the narrowest point, and can see the air in the biliary tree. Regular triad is the radiographic findings of pneumobilia, small bowel obstruction, and gallstone, usually in the iliac fossa. So whenever there is chronic inflammation of the gallbladder, there is the ultimate necrosis of the gallbladder wall, and then it also causes necrosis of the duodenal wall, and this is how the stone enters into the GI tract, and this is called as the gallstone ileus. And this stone can then go and obstruct the ileocecal valve, and the patient will present to you with abdominal pain and constipation. Now, the stages of development of acute cholecystitis. So there are a few stages like stage 1 and 2 and something. So we will discuss about that. So stage 1 is when the stone lodges into the common duct, or sorry, when the stone lodges in the cystic duct, it stimulates the stimulus of food causes the gallbladder contraction, and the stone is forced into the cystic duct. And then there is the mid-epigastric colic pain. That is pain-free interval occur. So it means that whenever the gallbladder contracts, there is pain, and whenever it relaxes, the pain is reduced. So it is called as pain-free interval. The pain is caused by the gallbladder contraction against the obstructed cystic duct. Also, there is the fever, chills, nausea, and vomiting without pain relief. And then comes the stage 2. So in stage 1, the stone is just lodging into the cystic duct. Now, whenever the stone gets impacted in the cystic duct, then the mucus accumulates behind the obstruction. The chemical irritation of the common bile duct or mucosal damage releases the phospholipase, which converts the biliary lecithin to the lysolecithin or recognized mucosal toxin, and then the bacterial overgrowth occurs with fluid invasion of the mucosa. The most common pathogen is Escherichia coli. The less common pathogens include Enterococcus and Clostridium perfringens. The pain shifts from the mid-epigastric area to the right upper quadrant, and it is dull, continuous aching type of pain, which can radiate to the right scapula or the soja. Then comes the stage 3. So in stage 3, the bacterial invasion through the mucosa into the gallbladder wall occurs, which causes localized peritonitis and rebound tenderness. And there is positive Murphy sign that we have seen in the beginning. There is absolute neutrophilic leukocytosis is present in a complete blood cell count, and the attack subsides if the stone passes through the through the cystic duct. Approximately 90% subside over the ensuing month, and if the attack does not subside, the gallbladder perforates, which is the next stage, or stage 4 called as perforation. While tension from the gallbladder, this tension compresses the lumens or intramural vessels, leading to the gangrenous necrosis and perforation. We're talking about the acute symptoms related to the Cholelithiasis. So symptoms vary depending on the location of the gallstones, as we have seen earlier. So gallstones in the gallbladder may be asymptomatic. Okay. Now this gallstone, when impacts in the cystic duct, then it causes acute cholecystitis and biliary colic. That's the obstruction of the common bile duct causes biliary colic and jaundice. The obstruction in the ampulla of Vater may cause jaundice and signs of pancreatitis. Obstruction of the hepatic duct may be asymptomatic, or it may cause jaundice and signs of impaction, signs of inflammation of the bile duct and the liver. So very important to know that the symptoms vary where the stone is, depending on where the stone is, and this will be tested in USMLE for examination. So please be confident in this topic. Now, complication of gallstones. So there can be a secondary obstruction leading to the cholangitis and liver abscess, biliary cirrhosis, and obstructive jaundice. Or there can be obstruction due to the cholecystitis itself, like secondary infection of the ulcer, the gallbladder carcinoma, very rarely, cholecystoenteric fistula causing gallstone ileus, and there can be obstruction leading to the pancreatitis features. So this is the gallstone ileus that I was trying to show you. So the adhesion forms following the pericholecystic inflammation, and the large stone causes pressure necrosis leading to the fistula, and then this gallstone travels through the small bowel and lodges in the ileum or the ileocecal valve, which is the narrowest part, and then it creates the mechanical small bowel obstruction. This is also the CT scan showing the gallstones with the gallbladder here in the arrow. Thank you for watching.